Actually, the key issue here is how to break the chain of transmission of TB in our community. How to do this? I think that we need to find all TB cases early, put them early on the right treatments, and help them during the course of the treatments. And also, it's our the job not stop there. We need to have a follow-up after completion of the treatment. I think these all things needs to be in a system. So earlier this month, we had the conference in Goa, India, and several civil society organizations came together with the support of the Molvayu Diagnostics and several other private sector as well in India. So the call that has been endorsed by over 200 organizations and individuals from more than 30 countries. And key issue, a key call is very simple. Find all TB and put all of them in the right treatments and diagnose them with a modern diagnostic tool, molecular test. I think that was the key message of the global call. So what we discussed during the summit in that conference is we have the global, TB is a global agenda. So there are several high-level meetings, there are many declarations, the WHO, the guidelines, the policies, all are there. But we need to translate all of these at the local level. When we see the global picture, it's a global target. And then when you come to at the national level, at the country level, national, like for example, Indonesia is a big country, over the 270 million population there. I don't think we can achieve this. No, those targets, those goals, we need to further break down at the local level. If you reach at the community level, at the local level, then you have the population, small population, that can be managed easily at the local level. So when we reach at the local level, actually there is no target. There is no target. We have to find all, and it's possible and doable and feasible. So I think the global agenda now need to translate it at the local level, and we need to, when we talk about find all TB, it's not only health sector. It's beyond the health sector. We have to come up with a whole of government approach and whole of societal approach. What do I mean by the whole of government approach? It's a health ministry or health department or health center is not only one to take care. Of course, they have to take care about treatment side. But when you go at the community level, we need to engage all the sector of the government. And whole of societal approach means now we are, even in this conference, I see our more of focus is more on the treatments, diagnosis, and still we are within the box. We have to go out of box. That is, there are people without TB, they have their right. How to protect their right to be exposed to the, their TB. So therefore, we need to protect the right of the people with TB and also right of the people without TB. So if we engage the people without TB, I think we can bring everyone together and we can bring all the TB people in a system and put them on the right treatments with the right diagnosis. I think that's the key message that I would like to highlight here. So again, in summary, local action, I think really is needed. We need to break down the national targets at the local level. And that's the key. Engage the local political leadership, that is mayors, governors, or at the local levels. So they manage their community, they know their community, and they have the capacity. They have the capacity to bring everyone together for better care and better services.
Can I just make a comment on that as well? Sorry, I came in late, so I'm Guy Marks. I'm the president of the union, and thank you, Tara, for that very good and Tara himself has done a huge amount of work on developing local capacity at the city and municipal level in tobacco control to some extent, but also for tuberculosis. And he made a very important point here, is that we have all focused entirely on, or almost entirely, on people who have TB and their immediate contacts. But in fact, we have not focused enough on the rest of the community who don't yet have TB and who don't want to get TB. And what can we do for them? They have rights too. And we need to focus on the rights of protecting people, the whole community, in high burden settings from having TB. I've given the analogy, and the problem, I think, is that fundamentally in high burden environments, people don't recognise that they're getting infected and that they're getting TB from having been infected. The analogy is tobacco and lung cancer. In a country or in a place where everybody, 100% of people smoke, it does not appear that smoking causes lung cancer. It appears that lung cancer is a genetic disease. The only reason we know that smoking causes lung cancer is because we can look at people who smoke and people who don't smoke and see this huge difference in the risk. For TB, in low burden settings, it is incredibly obvious that you get TB from being exposed to somebody with TB. Nearly everybody you get some reactivation of remote past TB infection, but the majority of cases of TB occur due to somebody having been exposed. If you're living in a high burden setting, Vietnam, India, South Africa, everybody is exposed all the time. It's as if everybody was smoking all the time. So most people don't recognise that they're actually getting TB through having been exposed to somebody. And that's why it's tending to be ignored as the driver of TB. But it is the driver of TB. You get TB in a high burden setting because you've been recently exposed to somebody with TB, usually within the last couple of years, sometimes within the last few months, and we need to stop that. And there's only one way of stopping that. That's by finding and treating all the people who have active TB, infectious forms of TB. With COVID, we tried to do the same thing. But with COVID, we didn't have any treatment. The only way we could stop, we had to find people with COVID, but the only way we could stop them from infecting other people was by isolating them, by putting them at home in quarantine. We used to have to do that with TB. That's why we had sanatoria. But since 70 years, we've had treatment that can rapidly render people non-infectious. That is the huge advantage of TB treatment, the huge advantage we have in TB, that as soon as you start on treatment, you become non-infectious to other people. But the key is to find all of these people. We can't just rely on people presenting with symptoms of TB, and we can't rely on just looking amongst so-called high-risk groups, because most TB in the community occurs in people who are not members of high-risk groups and who do not have significant symptoms, who do not have symptoms that drive them to a diagnosis. So the only way to find everybody is to actually screen everybody with a test such as radiology or a molecular test to make a diagnosis and then get them onto treatment quickly. And that's the strategy that we're talking about here. And so just to come one more thing from what Tara was saying, he's talking about targets, which is, that the targets are not, national targets for the number of cases you find are actually, well, they're better than nothing, but they're not actually the right target. The target is the number of people you're prepared not to find. How many people are left after you've done your screening? That's what should be the target. How many have we prepared to leave in the community infectious? So we need targets for that. We need to be able to measure it. It's not that easy, but you can measure that sort of thing. There are epidemiological approaches to doing that. But we need to move from targets for the number of cases found to targets for the number of cases not found. that is what is actually relevant to preventing transmission of TB disease. So I think that there's a paradigm shift in thinking needed here, and we're trying to advocate for that.